Hello, my name is Demetrio Dimitri. I am a second year internal medicine resident at University of Cincinnati Medical Center. Uh, and I will present this case presentation, in which I labeled or I titled "Not all SC segment elevation myocardial infarction are equal. Our intravascular look." I think I take this time to especially thank Dr. Saad, Ahmad, which has been a mentor and like a father figure for me, which has excited me and given me lots of motivation to pursue this case report and to pursue interventional cardiology in my life. I also thank my team and fellows Andrew Wells and Ahmed Souka for your support and continuous help on the cardiology world and your great support. Thank you very much, and I hope you enjoy this case as I did while I was on the CVICU. So, optical coherence tomography and intravascular ultrasound are the two most used intracoronary imaging modalities that allow for a real-time visualization of the vessel's lumen during a coronary angiography. This allowed the interventional for a better to understand better the underlying lesion characteristic and morphology, which potentially allows for an individualizing treatment and reduces the speculative work in the optimization of the therapy and the guidance of the therapy or the intervention. We present a rare case of the coronary thrombus causing a cardiac arrest in a 34-year-old male with no prior coronary artery disease, where the use of intracoronary imaging modalities or intracoronary imaging per se played a pivotal role on the management of this patient. So a 34-year-old male with prior history of tobacco use and unprovoked pulmonary embolism, previously on rivaroxaban, presented to the hospital following a cardiac arrest while playing basketball. The patient was resuscitated on the field by EMS and was brought to the hospital, intubated and unconscious, unresponsive, hypotensive, and bradycardic. EKG on admission, as you can see, showed an inferior. So what was concerning for an inferior wall myocardial infarction, giving the SC segment elevation on the inferior leads and reciprocal changes. The patient was taken for the cardiac catheterization emergently. On catheterization, the catheterization showed right coronary 100% occlusion, as you can see imaging 1A. We show a 100% occlusion. We decided to do balloon angiography based on the angiographic appearance of the vessel or of the lesion per se. And when we did, we had this view that we have here of image 1C, where we showed we have this vessel which showed a significant occlusion on the vessel. Following that, we decided to further interrogate the lesion using IVUS, which showed a thrombotic, significant thrombogenic burden within the blood vessel per se, with no underlying plaque rupture. After reviewing the IVUS imaging, we were a little dubious on the underlying morphology or underlying pathophysiology of what was going on, right? Based on this IVUS here in image 1B, we cannot say if there's really a plaque rupture or if there's more plaque within. So we decided to use optical coherence tomography, as you can see in the image 1D, where we can see blood vessels, which it's confirming that the patient has a thrombus within the intima, but not necessarily showing a plaque rupture that as the underlying cause of the disease. As we can see here, what we can see is no underlying coronary artery disease per se, but basically we can see a thrombotic occlusion more than all. So we decided to do aspiration thrombectomy, and post that we repeated the angiography and used IVUS, which showed complete thrombogenic resolutions that you can see in imaging 1E and 1F, which we can see TIMI-3-FO on angiography, and no further thrombus or coronary artery disease, underlying coronary artery disease on the vessel per se, and IVUS neither. So after that, the patient, after that intervention, the patient was brought to the CVICU, cardiovascular intensive care unit, where he was extubated and had full neurological recovery within 24 hours. The patient was the cause of this event. When we further worked up the patient, it was he was not adherent to his anticoagulation therapy, and the patient was discharged 72 hours later on triple therapy, which included aspirin, clopidogrel, and rivaroxaban, which he continued for a month, and had further had further plans to come as an outpatient and see the interventionalists. So why do I bring this case on the discussion, right? So while rapid reperfusion strategies in the setting of acute myocardial infarction is critical and paramount, the benefits of evaluating the lesion and using intracoronary imaging to assess the lesion and appreciating the pathophysiology to guide the management in certain patient populations, such as this one, which is a pretty healthy young population with no prior coronary artery disease, may be beneficial in this population, and there is possible benefits of not using further interventions that should be taken into consideration when we're seeing each case, right? So here, to conclude with my case presentation, this case highlights a potential use of intracoronary imaging modalities, especially in myocardial infarction, where using the technology that we have, we were able to rule out what we could think that was a plaque rupture, and we were able to guide the management based on the lesion characterization, thus successfully approving reperfusion of the myocardium while preventing an unnecessary stenting or unnecessary further intervention or coronary intervention in a rather young individual as this one, who doesn't really need it, or the benefits were not as are not as studied neither. So I finish here my presentation. My name is Demetrio Dimitri again, and my email is sharpddo@ucmail@uc.edu. I thank Ohio ACC significantly for helping residents who are in their path through pursuing a cardiology career. And thank you very much for all of you who are hearing me, and thank you for your support. Thank you for my team, and thank you for my university, which helped me a lot. I appreciate you all. Stay safe, and thanks. Hope you enjoyed it.